Is that okay? And then yeah, that's up to full screen.
Cool. Thank you, and it's great to be here and lovely to kind of follow Dan in the presentation that's also then going to follow with some more research data as well. As Joe said, I'm the clinician not for child and adolescent mental health services in Scotland, but in the second biggest health board in Scotland, so not the whole country. But I do also have an advisory role with the mental health division for the Scottish Government. So I have some link into an advisory role into policy development. And I'm starting off, I guess, picking up on that fact that Dan just presented to us about the leading cause of death being suicide. I put my hand up for the wrong bit, so I didn't have that quite right. But that sense of, oh, sorry, first of all, we have to put in a slide to say, do we have any conflict of interest? I don't, but I am using some cute photos of my friend and her baby during this presentation, but no money is exchanged. So we are in this situation, aren't we, where there's this terrible, terrible worry about the mental health and the state of our children and young people. We've heard about the suicide risk. We're hearing about reports about decline in wellbeing, particularly in our teenage girls. Demand for services like mine, child and adolescent mental health services, are soaring, and waiting times are soaring accordingly. Head teachers are concerned and feeling that their time is being pulled into dealing with emotional difficulties where actually their job should be teaching. And what's presented in the press, I think, is terribly unhelpful. This narrative of teenagers being in crisis, and of the only way to get help is to present in crisis to an emergency department, where you might be met with either in a children's emergency department or an adult one, with a whole range of people and settings, not the most conducive to helpful conversations about what's going on in someone's life. In Scotland, we've had a bit of a time of it, I'd have to say. In the last couple of years, there have been some major reports that have come out expressing lots of dissatisfaction about the services that are provided for children and young people's mental health. There was one which looked at the number of referrals which came to specialist services which were rejected without treatment, and that's known as the rejected referrals report. And then there was another independent one by Audit Scotland looking at funding and delivery of services, and that was also terribly critical. So what happened next? Well, out of this, there was a number of things that happened nationally, and I'm going to draw on again some of the risk and protective factors that Dan's just spoken to them, and think about how they might apply to a national context, but also to a local service context, and think about how that might fit together in terms of policy and evidence-based policy development and implementation. In Scotland, what we did on the back of those reports was there was a task force appointed in order to look at and basically solve the problem, come up with some suggestions as to what should happen. That task force has now become a programme board, which is making recommendations, and hopefully I'll pick up on some of those as I go through this presentation. We heard in the previous session about the role of social media, and again, this is something I think the press likes to talk about a lot, doesn't it? And to say actually it's all about the internet. That's why our kids are not sleeping, that's why our kids are doing badly, and it's all a negative thing. And what about social media? What do we know about use? And we've just heard in the previous session that actually it's only fairly recently that we've started to ask in surveys about the use of smartphones and start to think about the impact that smartphones and gaming might have on children's development. What can we speculate? What can we say with some confidence? I think we know that if somebody's looking at their phone rather than looking at their baby, then that is going to have an impact upon the reciprocity in that relationship, that sensitive, attuned relationship. But that might only happen for a couple of minutes. So it's not necessarily a bad thing, is it? It's just how much that is happening and how much that baby is being responded to and listened to. However, I think if we spend all of our time, I think the opening session when it was talking about the role modelling of parents and the amount of time we all spend on our screens and phones, and I'm definitely in that category, we're probably setting terribly bad examples, aren't we? I think we can say with some confidence, and again, we've heard that already many times today in the adolescent medicine stream, that probably one of the key risks is the impact that phones being on in the night is the impact on sleep, both in terms of children worrying about messages, young people worrying about messages they might be receiving from friends saying that bad things are going on in their life, from watching Netflix, as we heard, who sees sleep as their chief competitor, and just anxiously staying involved with chats about what's going on and that interrupting that ability to go to sleep. And as we've also mentioned previously, the impact of something that's quite light when actually you should be in dark to allow you to go to sleep. We know there's risk in terms of the kind of content that young people share online, and particularly we're aware of the risks when it's kind of pro-suicide information, all the horrible pro-ANA websites and information in terms of anorexia and self-harm, and then there's the cyberbullying as well. So there are risks, but I don't think it's quite as all one thing or all another. More recently, there's been some much more nuanced reports, I think, looking at the use of platforms like Instagram and Snapchat, and actually looking at it's not so much Instagram's bad, and it's bad for your sense of body image and well-being. And there were some reports earlier in the year that came out a bit like that, but more recently, it's been much more about who do you follow on Instagram, and what impact does that have on how you feel? What do you do on Snapchat? Do you only put a snap on if you're fully made up and you've got your fake tan on? Or do you do it when you're in your PJs and it's a bit more informal and actually everybody laughs together? And I think what we maybe need to do, and we can say with some confidence, that this, like anything else for young people, we need to help them to develop a sense of curiosity about it. So when I do this, how do I feel? One of my friends puts up lots of pictures of her cat, Tom. And when I follow and see photos of Tom, generally I laugh and think, oh, that's really funny. And that has a good effect on the way that I feel, not something that's going to affect my mood for the whole day, but it makes me smile. However, if I go to other content that may be political, or at the moment in the UK particularly, or if I were to watch a kind of frenetic fitness coach present what I should be doing in my next 5 minutes in terms of stretches, then I'm much more likely to feel grumpy or worse about my own body and the way I look. And it's the same for young people. But let's help them to think about that, to question that. It's not just one thing they're looking at, even if they're just on one platform like Insta. There's a whole range. And certainly clinically working, in my work I work a lot with young people with eating disorders, actually talking to girls about how do you feel when you follow so-and-so, who are the ones you'd say probably leave you feeling worse and less able to eat. They've actually come to the point where they have managed to unfollow people, but without me telling them they've got to do that, because I think I'd have started from that point of view of that's bad, they'd have ignored me. But it's that sense of curiosity that I think we as clinicians can generate in the young people that we work with. And then similarly, how do we co-create guidance with young people? Unless we ask them about the kinds of things that are likely to be helpful for them or that they think are risky, then we are only likely to come out with guidance around social media use, which is very adult-based and actually isn't appropriate for the iGeneration or for the digital natives. The kind of things I might think is helpful or not helpful is going to be very, very different from the young people that I work with. Dan's just spoken to us about ACEs and adverse childhood experiences. Well, in Scotland, there's been a lot of buzz about this. We've all been watching the film Resilience, and lots of people have become very concerned. And I think these are important. It's important to think about the impact of these things on children as they're growing up and developing, and their impact later in terms of health harming behaviours in adults. But I think it's also important to know that that list of ACEs is just 10 risk factors. It doesn't pick up the impact of parental loss, which we know is very, very important. And for paediatricians in the audience, it doesn't pick up the impact of physical illness on that developing sense of self, which we know is also a key risk factor. I think the research is really interesting, and that it's beginning to look at what are, if two children both experience 4 ACEs and one seems to manage that a bit better than the other, what are the factors that seem to be protective or mediating? And we're beginning to think about that and beginning to think about resilience, I think, in a more operationalized way. And one of the things that's come out very clearly is the importance of relationships in terms of protecting and moderating against risk. Obviously, often these will be parental relationships in the terms of the child's life, and that investment in parenting is vital. But also the Bellis research, more recently, Ross Whitehead and Eileen Scott and Donna Milne from Scotland, yay. Their recent research has looked at how we operationalise this trusted adult concept and how it might also apply to school teachers and to youth workers and to others working in the communities. So non-specialists, non-parents, people that can make a huge difference to young people. Mentioned protective factors, and Dan earlier mentioned parenting programs, just flagging up that we do know that there are some in terms of children that present at risk with behavioural challenges in terms of triple P in incredible years that do have tremendous evidence base. So my question would be, why don't we use them more? I work in an area that covers 4 localities. 2 localities use these programs really well, 2 don't. Why would we keep inventing something new when we've got good evidence for things that work? In Scotland as well, thinking about ACEs and thinking about trauma-informed practice, we have a specialist health board called NHS Education Scotland NES, who produce resources for the workforce, and they recently have been producing some really good resources around trauma-informed practice, and there are a series of animations, and the most recent one, Sowing Seeds, is people working with children and young people. It lasts about 2 minutes. It's well worth a watch, and might be the kind of thing that could easily be brought into a clinic setting or work with families. Thinking about the risk that we've mentioned for those children that experience physical illness, and this is a drawing by a little girl worrying about losing her hair when she has her chemo treatment for cancer. We know that lots of mental health presentations present in paediatric clinics. We know that community paediatricians are often the first people to see these children or to recognise these things. We know they also present in a hospital setting. And we can understand how this causes risk and disruption in an ordinary adolescent's development, because some of the normal adolescent developmental goals are achieved by challenging behaviours, testing boundaries, taking risks, experimenting with drugs, drink and sex. But for a child who's ill, it's much harder to be able to do that, and everybody around them probably feels much more anxious about them doing any of those things. And so the achievement of these ordinary developmental goals becomes more difficult. Independence and privacy can be harder to achieve. Used to having to go into a hospital or into a clinic and actually have to take the clothes off and get weighed or get measured, or all of those other things that we do to children when they're ill. Their differences from their peers become noticeable when actually being similar to your peers is so important for a teenager. And risk-taking for these teenagers can have more harmful effects. Thinking about children with diabetes who might take risk by drinking or by not eating or eating too much, and the impact that that can have can be devastating on them, whereas their peers can get away with that no problem, which is so unfair and can be experienced as so unfair for those kids. And that affects their identity, personal identity, and how that identity forms, doesn't it? It leaves them feeling different, it leaves them feeling separate from their peers. And so we get that, again, just I suppose to tease apart the risk factor for kids who have physical health problems. So what are we going to do about this? We've recognised that there's a huge gap between what specialist services can provide and what universal services we can provide. We've recognised that we seem to have this deteriorating mental health crisis in our teenagers. It's never all going to be provided, as Dan said, by health provision. So how are we going to start to address this? And I think we have to do it by working together. It's another way of expressing that kind of multi-sectoral, multi-agency approach. It's got to be about health and social care and education. It's got to be about communities. It's got to be about parents. It's got to be about faith communities too, thinking about what we can do together. But actually, we all find that quite difficult. And in times of financial austerity, it's even harder because we all get quite touchy about our budgets. And I know I get touchy about our budget. So it's not just everybody else does that. We all do that. It's hard. But unless we find ways of doing that and thinking together, then I don't think we're going to move forward at the pace that we need to move. So I'm just going to talk about a few practical, quite small scale things we've done in Lothian and Edinburgh that perhaps begin to test ways of doing this. Recognising comorbidity in paediatric, settings and thinking about neurology and epilepsy particularly. One of the things we started looking at in the Sick Children's Hospital in Edinburgh is a screening tool to be used in when kids come for their appointments to review with neurology, particularly children with epilepsy, recognising that symptoms that look very much like ADHD present very commonly alongside epilepsy. And it's a screening tool which is dead simple. It's a traffic lights in, red, amber, green, and there's a series of actions. Green, you don't need to do anything. Amber, the family gets some information about things that might be helpful for the child. Red, they join a psychosocial group. We've seen referrals from those clinics go down to the specialist CAMS clinic. The neurologists love it, the families are giving good feedback, and the children are quite happy. And there's interest in this across the piece in Scotland, because it's got a potential to do something quite useful, to intervene early, but to spread out that expertise away from the specialist mental health service. The other thing, there's a big celebration today in Edinburgh looking at a new intervention that's been developed in partnership with NHS Scotland again, and NHS Education Scotland, looking at low intensity interventions for anxiety, which they've called Liam. Let's introduce anxiety management. It's not a great name, but it's the name. It's basically a 6-session intervention for anxiety in children and young people who are experiencing mild to moderate anxiety. In Lothian, we have delivered this. We've trained over 100 people. We've just done an analysis of data of 120 children. So small numbers, but not bad numbers for just a kind of clinic setting. Thing is, we're training education staff, we're training school nurse staff to deliver this, we're training youth workers. They're trained, and then we're using implementation science to try to ensure that people stick to model by giving them fortnightly coaching and using a standard set of outcome measures. The results are great. They are clinically and statistically significant in terms of our outcome measures. The feedback from the children in terms of the way in which they've achieved their goals, which they set for themselves, is really, really positive, lovely stuff. And then the feedback from the people that are delivering the intervention is that sense of growing in confidence, they appreciating the fortnightly coaching, and then the feedback from head teachers again is very positive. So it's something that can be done at scale, safely and successfully, and it's being rolled out across Scotland. In Lothian, we've also looked at the other end of the scale, from moderate anxiety to what happens when a child gets diagnosed with anorexia. Terrifying. We know children die of this, and we know it's terrifying for families. And so we've set up, with some funding from the Scottish Government and from Technology Enabled Care, which was an EU grant, a website resource which looks at advice for parents in those early stages of what to do. So in those early stages, what we as clinicians do is stand around and say, this is really serious. If this doesn't change, something really terrible can happen to your child. And that is true. As a parent, your capacity to listen and to hear any more information at that point, I should imagine, is about 0. But what we do is we give them lots and lots of information in those early treatment appointments. So the idea of this website is that it puts all of that information online and people can access it in their own time. There's also some lovely videos of families whose children have been treated by the service and have recovered, and also some stories from young people who've recovered, and it's all co-created by the young people and parents. And again, it's one of those things that you can deliver for free at scale, and the feedback we're getting and continuing to collect is really positive. So these are just, I'll let you read these, but just I think the one we felt in the dark with the support we've had from our CAMs and having to wait for my questions to be answered takes its toll. It's good to have somewhere to go when I can get immediate information. You know, even when we're working with young people with eating disorders, where we may be seeing them 3 or 4 times a week, it can still feel like there are really long gaps between appointments. And this is one way of just building capacity and empowering parents to feel more confident to do that which they most want to do, which is to look after their children. very quickly, in terms of some of the policy things we've done in Scotland, we've been thinking about transitions, recognising that transitions from children's paediatric services and children's mental health services to adult services can be quite a risky time when sometimes adverse events do happen. I had the pleasure of working together with the Scottish Youth Parliament, who have work with young people in every area in Scotland to develop guidance, both for clinical services in terms of what we should be thinking about, but also guidance for young people themselves. When I started that work, most of the health boards had guidance on how to do transition well. The reality is very few of us were doing it. And so the hope is that by working with young people to co-create this guidance, then we'll actually get more empowered young people that will be more able to advocate for what their rights are. And it's a rights-based approach. Similarly, their carers then should know what they can ask for. So it's that idea of moving from a beautiful document, of which there are so many, aren't there, in health and social care, into something that actually makes a bit of a difference on the ground. Still easier said than done. That's what the young people's book looks like. The one that we produce for services, as you might anticipate, is an incredibly boring Word document, but the young people's one was great. And that's it really. I think it's just thinking about, we need to keep thinking about how do we develop resources that are actually going to help us to do what we need to do at capacity and at scale. And as Dan was saying, actually working with people who aren't necessarily paediatricians or general practitioners or psychologists or psychiatrists, but actually working with the communities out there to help people to acquire and develop skills. Again, most people are probably aware of this, but one of the best websites I think that we've got at the moment is the Minded one, which is produced by a group of organisations in the UK, and that's got more and more really, really helpful content on it. And then I've just added a few of the other I suppose few resources, things that we can bring into clinic, we can use, we can give to families to take away, we can put into letters when we've met people, to try to help people to feel more empowered and better informed, to look after themselves as parents, but also look after their children. Thank you.